She needs no introduction. She is an icon in India today for type 1 diabetes. The passion and compassion with which she works for type 1 diabetes is unparalleled. And she is going to talk about ambulatory care in type 1 diabetes. Over to you, Archana.
Thank you so much. It's a pleasure to be talking about a topic which, as Neeta said, I'm very passionate about. And very quickly, because I'm very well aware of the time that we have. And I will just be sharing my slides. Yes. So we're talking about ambulatory care in type 1 diabetes. Dr. Banshi very beautifully covered how difficult it is and where we are in India, all the hurdles as well as the way forward when it comes to type 1 diabetes care in India. I am going to specifically talk about the time between two hospitalizations, because what happens and what we have been seeing in last 20 years or so is that, yes, when a person comes in DKA, whether it's pediatric or adult, the person is very well managed, or for the first time when they're detected, it is quite unfortunate that still the largest numbers are detected in DKA and not early enough. But what happens between two visits is sometimes very, very difficult for a physician to handle. So assuming that today in our audience maximum, we are physicians who are not dealing with a large number of type 1 patients day in and day out. So my talk is a very simple algorithm kind of a thing, that what all would be needed if we wanted to give ambulatory care to each and every person with type 1 diabetes. So as said, this is a girl, she's Sanika, she is type 1 since she was 5 years old, and today she's a diabetes educator. So it's an art and a science. You need the education, the motivation, the counseling, but you also need the science of carb counting, the pump, CGMS, monitoring insulin techniques, and various regimes. So working in type 1 diabetes cannot be purely science, cannot be purely the medicine that we all know so well in our books or in our experiences. It has to be empathy, it has to be engaging with the person, because it's chronic self-care that we're talking about. And ultimately, as Dr. Rajiv mentioned, as everyone has mentioned, it has to be about empowering our patients. Again, we have to individualize them, and that can only happen with the very difficult task, I must say, of education, whether it's insulinization or monitoring, physical activity, investigations, follow-up, emergency care, or medical nutrition therapy. Each is individualized. But how is it possible for us in a busy practice to be able to do justice? And hence, we really need a team. So I would like to say here that if you are planning to work in type 1 diabetes, if you're working in type 1 diabetes, whether it's an online team, which is something which we are all getting used to, or it is outsourcing, or somebody who comes in once a week, twice a week, something, but we cannot do it without a team. We cannot do without educators, counselors, nutritionists, and we can have coaches, and we need leaders with type 1 diabetes, because peer learning and motivation is something that really works. What happens between two visits is a lot of lack of communications. Even if you're supplying the medicine, you're giving a prescription, you're teaching, and the communication is lost. I often get type 1 saying that, we go back motivated, and by the time we come back, the environment is so unfriendly. So we really need communication, whether it's social media, online meets, call a buddy who can help, WhatsApp groups or helplines, but an inter-visit communication channel can be created. Another very important part of ambulatory care is because they themselves may not do it. Hence, the hospital needs to maintain documentation. We do say that this is something as a given, but we all know that it doesn't always happen. And by documentation, we mean everything, the clinical documentation. I see so many children with type 1 diabetes who never had a growth chart, who did not have their BP monitored. So we really need all these documentations of their investigation, clinical findings, as well as a registration, including, for example, I'm using pictures of my patients here, but I have a form from them signed, which gives me permission to use them. So that is also very important for our own safety. Again, in ambulatory care, I would appeal to everyone to focus on the first month. This is a time they need hand-holding. Now, a new family is vulnerable. They have lots of myths around type 1 diabetes. We have to emphasize on insulin always. We have lost children who stopped their insulin, and which is something we cannot afford. And the honeymoon phase has to be warned about, because this is a time that all the babas and the alternative medicine people take advantage of, and they think it is curable. Alternate therapy has to be tackled at this center, and then the insulin and the monitoring techniques have to be taught at the right time. Hypoglycemia, which was talked about Dr. Arvind sir right now, is really, this is the time to teach them about it. We have to look out for comorbid conditions and individualize the treatment. Very quickly, we all know the regimes. I just want to say there's option for everyone. I work in low resource settings, yet every child I have is on a basal bolus regime. We do not compromise. I don't know, you can beg, borrow, steal, outsource, so refer to an NGO, do something, but give them the optimum care, because we want them not just to survive, but also to thrive. So have a physiological insulin regime wherever you are, even the remotest of tribal areas. Monitoring and logging. I understand that strips are expensive. CGMS, of course, wherever possible. But this is also not very difficult, and young people like to log on their phone today. Even in the remotest of villages, we have children who are doing online schooling today, so they're capable of logging. And if we can just take the time out to teach and motivate, this will happen and gives amazing result. Even if we cannot afford CGMS continuously, do try. So this is something at least once, like a diagnostic CGMS, once in a quarter, once in 6 months, because the kind of care, the kind of optimization of treatment that we can actually do, our educators can do, is going to change. So even if we are in low resource settings or in the optimum care centers, not to compromise in the ambulatory care is what I'm talking about. So nutrition can be as basic as a balanced plate, which a child in village can do. Identifying macros and visual carb counting, which we can teach even to the illiterate people. Do actual carb counting and self-meal planning. Everyone in the family can actually learn to do so. So this is a photograph of a child in a village who's showing us her balanced plate, and she can actually count her carbs, although she has illiterate working parents. So follow-up is something we often forget. So whether we follow ISPAD, ISPE, RSSDI, or any guideline, but do have an algorithm on how we are going to follow the child and their family, and they should know it. They should know what is to be checked where, so that wherever they go, they can actually do so. So let's not skip the right principles just because we feel that it's not available with us. Let's send them somewhere, let's refer them somewhere, let's outsource it, but not compromise with the quality of care. Education is the crux, whether it's basic education, comprehensive education, or advanced education. There are a lot of tools one can use, all the way from games to indigenous games in the local areas, to something like this is an earthen pot that children in the village use to store their insulin, where there's no refrigerator or electricity. So whatever it takes, but it is important that we should be able to give the optimum care to our children with type 1 diabetes. Peer group activity, we all know, makes a big difference. And with all the medicine in the world, if they're not motivated, we know we're not going to get adherence. And for that, the best way to do it is to have peers with type 1 talking to others, and having them as coaches and educators is probably the best way to make them want to do it better, because they have role models and they have experience and they have empathy. So they're the best people to have on your team when you're giving ambulatory care to people with type 1 diabetes. So with this, I would just like to say, I know I just rushed through it, yes, for want of time, but it's still easier said than done. So we think we can carb count, we can do this, we can do that, but it's still very, very complicated. It needs a lot of passion, and yet I feel we can do it. So do let us go ahead and give comprehensive ambulatory care to each type 1, because they do deserve to thrive and be successful in their lives. Thank you so much.